Okay, I'm here with Rich Willie, and I sent you a list of many things I want to talk about: patellofemoral pain, some of the bone stress injuries, Achilles. So why don't you tell people who you are?
Yeah, thanks, Jake. It's really great to be on the podcast. So I appreciate the invitation. So, my name is Rich Willie. I'm an associate professor at the University of Montana. I have a master's degree in physical therapy, and I have a PhD in biomechanics and movement science. So, I do research in running-related injuries. I've kind of done research in several different ones. Patellofemoral pain is where I got my start, and then kind of done a lot of work with Achilles tendon injuries, both Achilles tendinopathy as well as Achilles tendon ruptures. And then I've kind of, throughout my career, I've always done some work in bone stress injuries. But I would say over the last 5 to 6 years, I really have pivoted to spending most of my time working in bone health in athletes as well as bone stress injuries. So, yeah, I'm a little bit unique for a PT, PhD researcher, and that's that I worked as a clinician full time for 8 years, and I still treat now. So I still treat 3 to 4 hours a week, and I think that that's a big part of what I do. I think it really informs the teaching that I do in our physical therapy program, as well as working with clinicians. But I think it really helps me develop, I guess, clinically relevant research questions, things that I think would really matter to the average clinician. And I include myself in that group as well because I'm learning a lot as I go. And I don't know, this has really been a great career, and I really have a lot of fun every day with it. So besides that, I have an education and consulting business as well. It's called Montana Running Lab, and so I work with doing education with clinicians. And I do a lot of consulting with professional sports, as well as with runners. So just regular average Joe runners, if you will.
Yeah. So what's the reason you got into these things? The patellofemoral, the bone stress, the Achilles. Is it all running related or what?
Yeah, I mean, I guess the patellofemoral joint. Back when I was in PT school, I remember being in class, and this was when Chris Powers' work was first starting to come out, and this was even before he was doing a lot of stuff with posterior lateral hip musculature. He had a couple, I thought, really formative papers for me on patellofemoral joint biomechanics when I looked at patellofemoral contact forces, and I've always been super fascinated about like how a lot of these musculoskeletal conditions, there's a math component to it, and I really have always liked physics quite a bit, and so I really kind of latched onto the physics of patellofemoral joint loading and patellofemoral pain. And so at that point, I wanted to do a PhD, and but unfortunately, like when I first got out, I didn't. Well, not unfortunately, but fortunately, I worked as a clinician for several years, and I started working more and more with runners, and that was a group that I started doing a lot of gait analyses and gait retraining, if you will, at the time, which was pretty early. This was in the mid 2000s, and I knew I wanted to go back and get a PhD, so I actually talked to a couple people, Chris Powers being one of them, and ended up with Irene Davis at the University of Delaware. And so I started there in 2007 and had a chance to be in a really spectacular program, both from a PhD standpoint, but I also got to teach in that physical therapy program there and work in the clinic. And I would say that those are really important and formative time in my career professionally and also personally as well. So
Um, that the math component of patellofemoral. What exactly is it? You can kind of count. You can measure the patellofemoral joint forces, and that's like thought to correlate to pain. Is that what's going on?
yeah, I mean, I think then I was first learning a lot about some of the basics of how we move, things like the active length tension relationship, force velocity curve, and I could really see how that related a lot to patellofemoral pain and patellofemoral joint loading, but also some other concepts like patellofemoral joint stress and how when you've got the patellofemoral joint in different joint angles, patellofemoral joint stress is going to change considerably. And also just like some of the biomechanics of, like, for instance, doing a knee extension machine, while the motion is the same as a squat, from a knee like range of motion standpoint, the actual joint loads are considerably different than doing a squat. And how, like, if you know what you're doing from a biomechanical standpoint, you can kind of hit some really nice sweet spots when it comes to loading someone's patellofemoral joint just by manipulating moment arms and how the load's being applied. And then of course, at that time, frankly, we weren't doing a lot of like heavy loading with athletes. And this is from a rehab standpoint. And so I think, like, I don't know, I look back on my early career and think about like all the criticisms that I think get leveled at us physical therapists. And I think that it was pretty spot on for me. And so I really have gravitated toward doing heavy loading with most of my athletes, whether it be a bone stress injury, someone with a tendinopathy or patellofemoral pain. And I think understanding the biomechanics of what you're doing, not just from the joint level, but also how you can manipulate the muscle force capacity, makes a big difference for your patients. And I think it also will help you be more efficient with treating your patients. And I think it'll also help them get back to their sport a little smoother as well.
Yeah, so your patellofemoral pain, like I was telling you before we got on that, like I mean, all of my people are patellar tendon, like basketball athletes patellar tendon, but like some of them like have the signs of patellofemoral, and I still don't have a good answer. They're like, how is rehab different? Because I'm like, you still have to address the quadriceps and the surrounding musculature, and then progress in a way that makes sense back to sport. What are you doing with patellofemoral pain people? Is it a really complex thing? Is it like it seems for me, I guess, sorry to keep adding to this, but the patellar tendon people, like they have intense pain and they can't jump. And then when they get rehabbed, they can go back to jumping and it's like this extreme change that they know bad pain before pain's gone. With patellofemoral pain, is it like this dull pain that just kind of sticks around? So even if they might get a little bit of relief, but for me, I'm like, is it ever that extreme of a change where someone's like so satisfied with the results, or is it just this nagging, annoying pain? That was like 10 questions, but yeah.
No, 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 no. I think it's a good question. Yeah. So I always try to catch myself. I try not to use the term treatment when it comes to patellofemoral pain. I probably prefer the term management. And the reason why I say that is because I think up to 86% of people who have patellofemoral pain will experience some recurrence of that. And I think most injuries are like that too. We see that the number one reason why you might get Achilles tendinopathy is if you've had it in the past, and same thing with patellar tendinopathy. So what that means is that when you go out and you make a training load error, that that training load error is going to manifest itself as that past injury that you've had, and that's just because you still probably have those underlying risk factors. Like for tendon, for instance, you might still have some pathological tendon that has not recovered wholly, and so that might be part of it as well. But yeah, I mean, I think when you think about patellar tendinopathy and patellofemoral pain, it is important to differentiate between the two of them, both in your diagnosis, but also and how you're going to treat them. So for me, patellar tendinopathy, the way that might present is that most people will experience that warm up phenomenon where once they get warmed up, they'll start feeling a lot better. They may start feeling really quite good and actually forget they even have patellar tendinopathy until maybe the latter stages of a workout. But usually where that gets you is like the next morning, you wake up and you have that pain upon waking, which I know you're quite familiar with. But patellofemoral pain is a little bit different, and that's that patellofemoral pain kind of is just there, and not only is it there, but it also gets worse as you go on. So it kind of builds throughout a workout, and so you can actually use that knowledge to help you differentiate between the two of them. You can get someone like on a knee extension machine and have them do a set of some heavy knee extensions and then rest for a minute and then go again. And if it feels better, that usually is a good sign that it's not patellofemoral pain, and usually a good sign that it's probably patellar tendinopathy. And so you can differentiate between the two of them there. As far as treatments go, I don't know. I think like patellar tendinopathy is a little bit unique in that, we're starting to understand with some various imaging modalities that there is an underlying tissue pathology that's present. And with patellofemoral pain, I think I like calling patellofemoral pain the low back pain of the lower extremity, because we don't really know like what's causing this. What is our pain generator, if you will? And a lot of times people think, well, it's your articular cartilage is going bad, or I've got crepitus in my knee, and so because of that, I've got this patellofemoral pain. But I think it's important for us to keep in mind that articular cartilage is aneural, so It's not going to be a pain generator, so it's not your articular cartilage that is a problem. And in fact, if you go and get an MRI, the severity of any sort of osteochondral lesion that might be picked up by an MRI is not predictive of whether you have patellofemoral pain or not. It's not predictive of how severe your patellofemoral pain is. And then it's also not predictive of how long it's going to take you to recover from it. So a lot of times these articular cartilage lesions that show up on MRI end up being kind of, I don't know, spurious findings, if you will, just like a degenerative disc might be in the low back. So it's important not to get too hung up on imaging findings. Whereas like imaging with patellar tendinopathy can be somewhat helpful. It can help you understand like what's going on there. I don't know if I would use it necessarily to drive a lot of my treatments, but it can certainly help you understand exactly what sorts of pathologies are going on there. But yeah, and I think like patellar tendinopathy versus patellofemoral pain, I think anytime you're thinking about that knee extensor mechanism, I think it's just really important to be able to differentiate between all the other competing diagnoses, because really both of those are diagnoses of like what we would call exclusion. You have to exclude other items that might be contributing to that. So, and for patellar fat pad, for instance, is going to be an important one, particularly in female athletes. Iliotibial band pain, another one. An adolescent athlete, Cindy Larson-Johansson syndrome or Osgood-Schlatters, and a lot of those are pretty easy to get rid of, but you definitely need to have those on your radar based on the person who's coming in to seeing you.
Hmm. I didn't know the infrapatellar fat pads more common in females. Why is that?
Yeah, it is. It does. Well, I mean, first off, patellofemoral pain is much more common in females versus males, and that's the other thing too, is that males tend to get patellar tendinopathy more often than females do. So you can kind of start. If you have a male coming in who has knee pain, you should start thinking probably patellar tendinopathy. Female coming in, has knee pain, you should start thinking, well, patellofemoral pain or the patellar fat pad syndrome. One of the main risk factors for infrapatellar fat pad syndrome is that you can go into a lot of genia recurvatum, so you can hyperextend your knees. And so, I know a stereotypical type person would be, I don't know, a swimmer, like a butterfly swimmer, who can stand and really kind of hang on the back of their knees, and they're going into a lot of hyperextension. And what that does is that your inferior pole of your patella can pinch that fat pad and can get it kind of irritated and also inflamed. So we see that movement pattern there, but also females tend to have a little bit of a higher riding patella often, and so that's also a major risk factor for some sort of infrapatellar fat pad issue. And so when you put those two things together, a lot of times those people are female, and certainly we see that in males. We just don't see that, and we certainly see it just a lot more in female athletes.
Hmm. Um, the probably actually because I recently listened to one of your old shows. You were well, actually in your research article too. It was on the Q angle because I'm sure people would think, oh, females Q angle, males not. That's why there's more patellofemoral pain, but that's not the case, right? Can you explain why that is?
Yeah. So there are a lot of like really important like risk factors, or what we used to perceive as risk factors, and it's important for us to kind of dispel some of these myths. And so, one of those is that like a higher Q angle, if you will. So there's two different ways to measure it. Statically, I think, is what most people think of. So this is measuring the angle from your anterior inferior iliac spine to the midpoint of your patella to your tibial tuberosity. So that angle there, we typically see that angle being a little bit greater in females. But and I mean like 3 to 4 degrees greater. So we're talking like 15 degrees in females, 12 degrees in males. So it's not a big difference there. So, but when you look at the prospective data, so data that is collected before people get injuries, this static Q angle does not predict who's going to develop patellofemoral pain. And so it's important when we're thinking about, I don't know, like the adolescent athlete who might have patellofemoral pain. It's really important that healthcare practitioners don't look at their alignment and say, well, of course you have patellofemoral pain, look at your alignment. And we now know that how someone is put together doesn't really relate to how or if they're going to develop patellofemoral pain, or how long they're going to have it, or how severe it's going to be. So we really need to move away from talking about, I guess, posture and structure when it comes to these injuries. And same thing goes also with foot pronation too. So foot pronation used to be thought to be a big driver when it came to patellofemoral pain, but more and more we're starting to see evidence that it doesn't seem to relate to patellofemoral pain whatsoever.
Hmm. Um, so one of those questions was on how you, I guess, how you manage it. So we'll get to that. I'm still curious on you talk about the articular cartilage articular cartilage is aneural. I did a show with Claire Robertson, kind of speculating on what is the pain generator, what is the cause, and she was kind of saying it's like a pressure thing, like a increased, maybe that's like a subjective thing. Maybe you can't measure that. Um, what is causing the pain at the
Yeah,
patellofemoral?
right. What is it? Yeah, I would say no one really knows. I mean, there are certainly some well thought out theories on this. Um, so when you look at like what is highly innervated, we've got our infrapatellar fat pad. So that is, if you've ever had like a knee arthroscopy, they end up going through that, and that's one of the big reasons why you have a lot of anterior knee pain after that surgery. So that could be a potential pain driver. The synovium can get very irritated. But then the other thing too, and this is what Claire's talking about, is you can get some subchondral bone edema. So for someone who has really persistent patellofemoral pain, sometimes with very certain like MRI sequences, you can pick up a little bit of this bony edema, and because of that, you've got increased pressure in your patella or increased pressure in your trochlea, and when you compress that patella into that trochlea, you can get an increase in pain because of that, because the joint stress ends up going up quite a bit. So I would say that that's probably the current theory when it comes to people who have like long-standing patellofemoral pain. And I certainly have seen that from an imaging standpoint. But for people who just kind of go out and they overdo it and they get patellofemoral pain, that's not something that's showing up on imaging. And so, again, we don't necessarily know why it is, and I don't know necessarily if we have to. I think for me, I just see it as, look, you just did too much for your knee. Your knee's not happy. You kind of overcooked it. You need to take a step back and maybe think about, I don't know, re-examining like how you're increasing your workloads on your knee. But let's rebuild your capacity, and the idea being that we need to rebuild your capacity to the point where it's greater than what you're going to need for whatever sport you're doing, and then we can get you back out like full participation, and hopefully this won't come back again. So we do know that, and again, this goes back to that bony edema, but we do know that the number one predictor on how quickly you're going to recover from patellofemoral pain is how long you've had it. So if you've had patellofemoral pain for 2 to 3 months, the likelihood that you're going to recover from it is really quite good. If you've had patellofemoral pain for a couple of years, it's going to be more challenging to you. And so, again, this kind of goes back to like, I think people acknowledging that patellofemoral pain is not necessarily a normal part of growing, and that when someone gets patellofemoral pain, it's important to get them in to see someone who knows what they're doing and get some treatment early so you can get on top of it before it becomes this persistent issue. So one of the things that I see a lot in female athletes, and particularly high school level, so they might go see like their general practitioner and they've got patellofemoral pain, and the family doctor might say, well, you're female and it's a growing pain and you're going to grow out of it. But what we now know about patellofemoral pain is that it's not this condition that seems to go away on its own. It is something that requires some sort of intervention. Because what we see is that high schoolers who have patellofemoral pain turn into young adults who have patellofemoral pain. And if that happens, the other thing we also see too is activity levels start to decline. Athletes start quitting sports. And so I think intervening pretty early on is going to be important for these athletes.
That reminds me. I think this was in your paper. It was people with the patellofemoral pain have a lower step count. Is that a thing? Like they
Yeah,
move
kind of for
less?
like for walking, like overall walking levels.
Yeah, was that a thing with the patellofemoral? Is like
Yeah,
the
yeah.
activity level goes. Yeah.
Some people have looked at that. I haven't personally, but yeah, we're starting to see that more and more. That once someone gets patellofemoral pain, the big thing that happens is that their overall step count during a day goes down. And so, I mean, obviously, that's just some surrogate for overall like activity levels. And so, as someone reduces the amount of activity, their overall load capacity is gonna also decrease. And so you've got this athlete who was playing volleyball or basketball or running, 5, 8 miles or something like that. And now they've got patellofemoral pain and now they're struggling to go up and down stairs. And so that can be like pretty frightening for the patient and this athlete. And they're like, what's going on with me? There's, something wrong with my knee and I need to get this thing fixed. And the reality of it is that you just need to just kind of slowly rebuild that athlete. It's going to take some time. And so again, the longer this person has had this injury, the greater kind of retraction or withdrawal of their overall activity levels is going to be. It's going to take you longer to build that person back up.
Oh, is there a relation with patellar instability or like patellar just jumping around the tracks? Is there any relation with that and patellofemoral pain?
Yeah, so that's another one too that I think is important to kind of dispel. So there's a difference between patellofemoral pain and patellar instability. Those are two different diagnoses, and so a skilled clinician should be able to differentiate between the two of them. So patellar instability doesn't necessarily mean that this patella that's dislocating. It may have, but for the most part, a lot of times we see these like little slips or patellar subluxations, if you will, where the patella kind of slips out and then it kind of reduces on its own, and those might be like little, like almost like micro instabilities, if you will. Most people don't have that. Most people have true patellofemoral pain, and so patellar tracking, patellar alignment, all these different things that we used to think that related to patellofemoral pain don't seem to relate to patellofemoral pain for real. And so the idea that you can go in and get there's this radiographic view. It's called the sunrise view, where the orthopedic surgeon might have your knee kind of at a 30-degree angle, and they'll look at the angle of that patella and draw some lines there. And if the lines intersect, they're like, well, you've got bad alignment. We need to think about doing like a lateral release to your lateral retinaculum. That was kind of the way that patellofemoral pain was treated surgically in the 90s and 2000s, and you still hear about it now. But I think anybody who's been around the field long enough knows that lateral retinacular releases don't seem to make much difference. And certainly the person who should not get a lateral release is someone who's got patellar instability. So if you've got an unstable patella, the last thing you want to do is introduce more instability to it by releasing some of the tight tissues on the outside of the knee. That's just going to make your knee even more unstable. So, and the reason why we know this is not just because of advancements in MRI, there's different imaging sequences, because now we can look at dynamic MRI like images where we can have someone do a squat and we can look at how much their patella is tracking laterally or not. So we know from that aspect that it doesn't seem to relate very much to who has patellofemoral pain. But the second part of it too is that we can also look at some of the different treatments that seem to work. And so we know that quadricep strengthening makes a really big difference for people who have patellofemoral pain, and that doesn't really seem to have any effect on patellar tracking or on patellofemoral contact area at all. We also know too that that patellar taping seems to have this really important effect on the amount of pain someone's experiencing when they're doing some sort of patellar loading activity, like a knee extension machine or squatting. And so for me, I use a lot of patellar taping. I do a lot of taping. I don't get too excited about how I'm taping this person, about realigning their knee. I'm just giving them a nice medial pull. And the reason why that's kind of important is because when you look at some of these newer MRI studies, it shows that when you tape someone's knee, it might look great on the table, but this as soon as they start doing a squat, this patella is gonna move back to where it was before. So it doesn't seem to be that taping is really changing this person's patellofemoral joint alignment. It's probably just that really noxious stimulus of this tape just pulling the heck out of this person's skin when they're doing some sort of activity that seems to provide some sort of, like, I don't know, efferent input to the central nervous system that is distracting their central nervous system so they can lift more weight. And for me, like whenever I'm treating someone who has this sort of injury, I always come back to how can I get more weight on this person? And if that means I'm taping them, awesome. If it means that I'm using some sort of foot orthoses, same deal. I don't really care what's happening. What matters is that I can get more weight on this person, which means I'm getting a greater stimulus to them, both to their central nervous system, but also hopefully to rebuild their strength. So we can put that aside and say that taping seems to help, and it does seem to help for the first 6 to 12 weeks of a person's rehab program, and after that, it doesn't seem to be as effective. But then on the other side, we can take a look at patellar bracing. So if you have someone with this big lateral J brace that's got a strap that's kind of realigning your patella and pulling it medially, that definitely changes patellofemoral joint alignment. And not only does it change it, but when you start moving, it keeps it in that position as well. And so it's a very stable brace. And that seems to work really well with someone who has patellar instability, someone who's got this patella who seems to be slipping out. And those people often end up going on to get surgery anyway. But it does not seem to improve the outcomes for people who have patellofemoral pain. So we've got this intervention, this patellar brace that changes alignment, doesn't seem to cause, or it doesn't seem to really speed things up at all. Then we've got patellar taping that doesn't have any effect on alignment, and that does seem to have a pretty large effect. So when we start kind of like reverse engineering some of these interventions that we've just kind of happened upon, it can help us try to understand like what's going on and what's going to help someone out from a recovery standpoint.
That yeah, I've been aware of that taping for a while. I think Joe Cook said like diamond taping. What is the exact? Does it not really matter? Can people do this on their own, or they kind of need someone to do it on their knee?
Yeah, no, patellar taping is something that I train patients to do it to themselves. I mean, I think the most important thing is to go get a nice rigid tape. So Luco tape, which is this kind of tan or brown tape you can buy from Amazon. It is a little bit expensive, but you really want to get some sort of rigid tape. And the reason why you want the rigid tape is because you need something that's going to really stretch the skin. So like K tape, or I don't know, some of the softer tapes like a Kendall type tape does not seem to make any difference. And in fact, there's some really nice RCTs out there that show that kinesio taping doesn't seem to help patellofemoral pain at all, but we've got Luco tape, which is this nice rigid tape that's going to stay on for a while, seems to make a really nice difference. And again, what it is, it's because it's pulling on the skin and providing this like mechanical stimulation to your skin when you're doing some sort of activity. So yeah, no, there's some really nice YouTube videos that are out there. There are lots of different taping techniques. I actually have a video that I just created that I'll probably throw up on YouTube before too long, but I tend to go simpler than I know a lot of people get into really complicated taping schemes. And so, the original person was Jenny McConnell. She's a physical therapist from Australia, and she came up with this McConnell taping. And she looks at like the tip or the spin or whatever of their patella, and she's angling the tape to kind of correct for that. But again, it seems like no matter how well intentioned you are or how skilled you are, as soon as you start contracting your quadricep, that's going to slip out of place. And so for me, I just put some anchors on the outside, some tape anchors on the outside of the knee, and then I do three progressively larger strips pulling their patella immediately, and put another anchor on top of that, and then leave it at that. So you can do for like fat pad syndrome, you can do kind of like this V technique, which is going to be down below this person's patella, and the whole reason for that is basically to pull that fat pad and kind of stretch it out a little bit, and so it's not getting pinched, and it's just kind of trying to clear it from underneath your patellar tendon and inferior pole.
Um, so this it's almost like the way I'm looking at it is like the flexing your knee under load is like the can be the aggravating thing for patellofemoral pain, but it's like you need to do that to start to build the quads. What else? Like, what are you doing for the quads in those people? Are you doing? I think in a past show you were saying how you'll see hip deficits in the patellofemoral people. Are you doing stuff for the calves? Like, what are all the things that you're kind of looking at for someone with patellofemoral pain?
Yeah, well, yeah, this is I would say something that's really evolved a lot in the last, I don't know, 5, 6 years. So it used to be thought that people had patellofemoral pain because they had weak hips, and so their knee was really diving in a lot because of that. Um, but there have been a couple kind of nice studies that have come out that have kind of, I guess, disputed that. And I think, some of again, these prospective studies are really informative. And that's again, these people, they're studies they'll look at athletes before they develop patellofemoral pain, take a bunch of measures, whether it be strength or alignment or what have you, and then follow them for a period of time and then see who gets patellofemoral pain. And hip strength has been one of those because, again, Chris Powers and some other people, I would consider myself one of those people in the early stages as far as putting out papers looking at hip strength. And really thought that people who had weak hips would go on to develop this patellofemoral pain. But what seems to happen actually is that people who have weak hips don't necessarily go on to get patellofemoral pain. It's not a predisposing risk factor. However, if you've ever had patellofemoral pain, you've ever treated someone who has this injury, you know that people who come into your clinic will have hip weakness. And so, and the evidence is very clear on that. So when you look at these cross-sectional studies, so people who have patellofemoral pain, they almost always have some sort of hip weakness. But people who go on to develop patellofemoral pain who don't have it now do not necessarily have hip weakness. And so what that can tell us is that can tell us that hip weakness doesn't necessarily cause patellofemoral pain. It's the other way around. The patellofemoral pain is causing hip weakness. And that's because pain has this really strong inhibitory effect. It's going to inhibit the proximal musculature. And this is, I think a lot of times you see this with other injuries too, and you see people kind of get a little thrown around like by these cross-sectional studies that you see it most recently in like ankle sprain, the ankle sprain literature. Someone sprains their ankle and then they're like, well, let's go look up this person's hip strength. And because they're thinking, well, maybe they don't have this hip mobility or hip stability that they need. And sure enough, they've got hip weakness, but that's because they've got this very painful ankle and there's this very strong inhibitory effect. We see it also with Achilles tendinopathy. And so now you're starting to see a lot of people talking about doing a lot of hip strengthening for people who have Achilles tendinopathy. And I would say that that's fine. I think go ahead and do that, but it shouldn't take time and energy away from doing what really works, which is progressive loading on your Achilles tendon or restoring range of motion and balance in your foot and ankle complex for someone who has like a lateral ankle sprain. So yeah, so for someone who has patellofemoral pain, I almost always do some sort of hip strengthening with them. But what I know that I'm doing is that I'm not changing their alignment, changing how they move. I am helping them do is learn to accept some load on that limb. And we're basically doing a graded exposure to their central nervous system and saying, hey, look, I know this limb is painful. It's okay. We're going to start being a little bit sneaky about how we're loading them. We're going to start loading a little bit away from this very painful patellofemoral joint. And again, this is someone who's has a very irritable patellofemoral joint. Might just take a little bit easy on that and spend some time doing some proximal loading. And then we might also do some plantar flexor loading as well. And then eventually we'll start sneaking in some quadricep strengthening. So things like step ups or some forward lunges before we get them on some sort of like, I don't know, like a heavy loading program for their quadriceps. And that would be heavy squats, knee extension machine, where you're going to be getting a lot of load on that patellofemoral joint. I think if you go after that right from the get-go for people who have patellofemoral pain, they're probably not going to do very well. Versus someone who has patellar tendinopathy, that's what you would start doing on day one. On day one, you're going to start doing heavy knee extensions. And if you like every day that you delay doing that with someone who has patellar tendinopathy is one more day they're going to have patellar tendinopathy. But if you do that with someone who has really irritable patellofemoral pain, they're going to get really flared up and you're going to take a couple steps back. So for me, I always kind of go a little bit slow. I definitely want to get in there and start doing some isolated quadricep strengthening. And that's always where I'm headed. I don't start doing things like patellar taping until we start doing knee extensions. So I always wait for that, maybe for 3-4 weeks, and I'll start. Okay, so today I'm going to teach you how to, tape your knee and see if it works. And of course, the only way that I know that that's going to work is that I'll have them do some heavy knee extensions with and without the tape. And if the tape helps, we'll do it. We'll keep doing it for a while. And if it doesn't make a difference, well, that's not the right thing for them, and we'll move on just to keep doing our normal strengthening. So, but there's a really cool randomized control trial that came out of Brazil, and I'll tell you what, Brazil is I don't know, I would say maybe a decade ago, you wouldn't think of them as being a source of really high level physical therapy publications, but I think some of the papers that they've been putting out over the last 10, 15 years have been really excellent. And so this paper kind of made me kind of really reinforce this bias of mine, and that was rather than doing posterolateral hip strengthening, they actually did a lot of Copenhagen hip exercises. So if you're familiar with those, they're basically adductor exercises. So they did adductor exercises. There's an RCT. They had one group doing posterolateral hip musculature strengthening. The other group they had doing these Copenhagen hip adductor strengthening exercises. And there's no difference between the two groups when it came to outcomes with these people who had patellofemoral pain. So again, I don't think we probably have to be as specific as we used to think when it comes to patellofemoral pain. Again, I think with patellar tendinopathy, I think you have to be very specific because you're definitely trying to get some sort of mechanical stimulus to this person's patellar tendon to drive tissue adaptations. I think for patellofemoral pain, I think there's much more of a central nervous system component. But at the end of the day, you 100% need to get heavy load on both of these athletes. And we know that people who have patellofemoral pain, who go through a heavier loading program, tend to have better recoveries, and they tend to have recoveries that last longer as well.
Hmm. Yeah, it makes a whole lot of sense. For the posterolateral hip exercises, what exactly would you be hitting?
Well, let's see here. So yeah, for me, I mean, I'll usually do some exercises focusing on resisted hip abduction. So I'll start doing some, sideline activities for some. This is for someone who's really irritable. I might do. I really like doing hip thrusters. I usually like doing those with some heavy, some sort of heavy weight with them. Um, if they're not as irritable, I'll start doing stuff in standing. So I'll start doing maybe some four-way hip exercises with a cable column. I'll start doing those exercises pretty early as well. So, and then and again, lunges I think like a Bulgarian split squat is such a great exercise because you can really modify how you're putting load on that person. So you can shift load to their foot and ankle, to their hip, to their knee based on like trunk position and foot position. And so we'll start off doing you have someone do like a Bulgarian split squat where they're leaning forward and they've got a really wide step so that that leading leg is really far out in front of them. And so by doing that, they've got a lot of load on their hip extensors, and then we'll gradually have them adopt a more upright trunk, and then we'll gradually start pulling that foot up underneath their body so we can start shifting more and more load onto their patellofemoral joint. So I don't know. I think we probably don't need to make rehab too complicated. For me, I tend to try to keep exercises two, maybe three exercises for someone's program. And I usually have them come to see me like once every 2 weeks, with the idea being that they're learning how to self progress in between. I tell them like what to do. I always say, hey, if something goes wrong, shoot me an email. We'll walk through it. But for the most part, I think like getting patients to be independent in their care is going to be a really important part of this. And again, part of that is telling them that they don't have to, if you're doing more than 2 to 3 exercises, I think for me, that's always a good sign that I don't really understand what's going on. If I'm throwing a bunch of exercises at a patient, I think like if you know what you're doing, you should be able to come up with just 2 to 3 exercises that are going to get it done for them.
Mhm. The I remember in your paper, I think you had, you'll have to correct me, 4 subgroups of the patellofemoral pain. And I had actually, I think 3 years ago, made a YouTube video kind of on that because people were asking me about patellofemoral. And I had one experience where I had played basketball and dunked one day, and then I traveled and I did heavy deadlifts, vertical jump testing. I must have played basketball again. I was staying at a hotel and like I couldn't walk. Like walking up and down stairs was like I had just cooked my I think bilateral patellofemoral pain. And it's to the point where like I think 4 or 5 days in, I'm like, is this ever gonna go away? And I didn't know what to do, and it just went away in like a few days for me. And I kind of thought for myself that must have been the subgroup of like that acute overload, where if
Yep.
I just remove the what's provoking the patellofemoral joint, it's just gonna go away. Um, the but that's usually what are those other subgroups? How much does that change what you're doing?
Yeah, so you're talking about the clinical practice guideline that we published, and I think we had several different groups in there. I don't know. I would say I kind of. I mean, for me, I would say I probably don't get down into that level of division with how I'm treating most patients. So, for me, I tend to think about it as a very acute overload, and if so, what can we do to keep this person as active as possible? And so usually I'm going to do some sort of patellar, or patellofemoral joint loading exercises. I really like stationary bike a lot. I think that's one of the best things you can do when you get really flared up. And so I tend to do that. I think from a strengthening standpoint, again, I basically just what I described is how I work with most patients. I will say that since we published that, there's been some literature that has come out, and the foot and ankle is a great example of this. And so it used to be thought there's a clinical prediction rule that came out that found that if your foot width changes more than a centimeter or something like that when you go from sit to stand, that you might benefit from a foot orthosis. And but there was, I think, the largest randomized control trial ever done in patellofemoral pain looked at that. So they had people do a foot orthoses and also did like quadricep and hip strengthening, like what we've been talking about. And one of the things that they found was that foot posture or foot pronation or anything like that has no bearing on whether or not a foot orthosis is going to help you. And so the best way to tell if a foot orthosis is going to help you is essentially go up and down stairs when you have patellofemoral pain, or do like some repetitive like forward step downs, and do that with and without your foot orthoses in. And if it makes a difference, then go with it. Don't worry so much about foot alignment. And that's kind of what I do now. So, and I think when you look back at that clinical practice guideline, which by the way is actually up for renewal, those are good for 5 years, and I believe that article is 5 years. That'll be one of the things that we're going to change in there is changing, just basically updating. I mean, science has moved on, and so should our practice guideline as well.
As far as you said, you want people to stay as active as possible, and like you work with a lot of runners. You've had a few different ways of managing patellofemoral loads with running. Could you get into that?
Yeah, yeah, 100%. Yeah, so, yeah, I mean, so I look back at how I was treating this injury. I don't know, 4 or 5 years ago, and certainly a decade ago, and it really has evolved. I would say that when I first came out with my PhD in biomechanics in 2011, I was doing gait analyses on almost every runner. And I was doing some sort of gait retraining on most runners as well. So meaning I was having them work on their alignment when they were running. I was cueing them to increase their step rate. I think those are probably going to be the two biggest changes that I would do. But I was doing that on a lot of runners. Um, since then, some really nice papers have come out looking at different ways that we can shift some load around. And really, that's all you're doing whenever you're running or lifting weights. And as long as you're lifting the same amount of weight, and if you are changing your body mechanics, all you're doing is you're not changing the amount of load on this person on this system. You're just distributing the load across different joints. And so, one of the easiest ways to do that is through uphill treadmill running. And so, if you just run with a 3 to 5% incline on a treadmill, you're going to reduce patellofemoral joint loads by 25%. I mean, that's a dramatic decrease. And so, of course, you're splitting that between your hip and your plantar flexors. And so, I mean, obviously, that would be something you need to be careful of if you've got, a history of Achilles tendinopathy or proximal hamstring tendinopathy. But that's one of the most efficient ways to keep someone running. And so, get them on a treadmill. It's not the most glamorous thing to do, but I don't know, some good things to watch on Netflix, I guess. But running on a treadmill, running uphill is particularly if someone's got a race coming up and they've got themselves really flared up. Um, that's a really good way to keep conditioning levels quite high while you're also doing rehab on the side. You have to do both of them together. And hopefully those two things will work well together and you can keep this person's load capacity pretty high. At the same time, you're also doing some very specific rehabilitation for this person's patellofemoral pain. So I would say uphill running is one of the absolute best things to do. And then you don't have to do anything else. Like when they're doing uphill running, you don't have to like cue them to increase their step rate, for instance. And again, we know increasing step rate is one of the most efficient things that you can do to reduce patellofemoral joint loading. And so if you increase your running cadence by 5 to 10%, we know that patellofemoral joint loads will decline about between 10 and 15%. So there's a really nice payoff there. But you don't have to do that when you're running uphill because we naturally shorten our step length anyway. So you naturally adopt a higher cadence. And so where you don't have to like where you start like want to start thinking about running with a higher cadence for someone who has patellofemoral pain is obviously eventually you want to start bringing that treadmill back down to level, and then at that point then you're gonna teach them how to run with a higher cadence. And so for that we typically I know some people use metronomes or have them run to different like beats of music, and some of that might work for some patients, but for us we find that it doesn't work well for our runners. Most runners come in with a Garmin or a Sunto or some sort of running GPS watch, and I would say almost everybody's GPS watch nowadays has the capability to give you real time biofeedback on your running cadence. And so we've published a couple studies on that, and that's what we do a lot of. So if someone comes in and they're having a hard time getting or transitioning back to level running, we'll start doing. I'll cue them to run with a higher cadence. We'll teach them how to do it in our clinic or in our lab, and then we have them transition to doing that outside. And we have them keep looking at their watch over the course of 6 runs. And after you've done that for about 6 runs, you tend to adopt this pattern. It's a little bit hard at first. And of course, the first couple of runs, it feels like a struggle and you don't really want to do it, but it also reduces this person's knee pain. So usually people are pretty motivated to do it. And then after you've done that for 6 sessions or so, and you've been looking at your watch, you can kind of start weaning yourself off that watch, and it becomes this new movement pattern for you, and you end up adopting it a lot, or pretty easily. You don't have to do any major changes in how someone's running. Like you'll see some people advocate for like, I don't know, like something as drastic as like a I don't know, 4-foot strike. And a 4-foot strike really reduces your patellofemoral joint loads, but that's going to dramatically increase your Achilles tendon forces as well. And so we see a lot of runners who have tried switching over to a 4-foot strike for various reasons, because they saw on Instagram that it would help them run faster, or because they had patellofemoral pain. And of course they end up getting Achilles tendinopathy, or, so maybe like a bone stress injury in their, like one of their metatarsals. So we tend to discourage people from doing that, because the same reduction in patellofemoral joint loads that you see with a 4-foot strike is the same reduction that you see with a running with a higher cadence, but you don't have that greater injury potential. And the reason for that is because you tend to take shorter steps. And so the overall load on the system has actually decreased versus with a 4-foot strike. You're not changing the load on this person. You're just shifting that load around a little bit. And that's where you can get yourself in trouble.
Hmm. Yeah, I learned that my family is a lot of people that like to run marathons. And I was back in the day like anti-marathon because I was all about like whatever the Ripito thing about just lifting heavy for whatever. But then I got into Kelly Starrett back in the day, and he was talking about the 4-foot strike pattern. So I went for a run with my uncles and did all 4-foot, maybe like 3 miles, and then college started the next week, and I had a hard time walking up and down stairs because my calves hurt so bad, and that
Yep.
must have lasted for like 3 weeks. But I could definitely see that happening. Where do you stand with like you put me on that interplay of or that opposing forces of like the incline hill is gonna lessen the patellofemoral, but then if you go decline, like a downhill, gonna be more patellofemoral, and then it's like the Achilles has the opposite effects, right?
Yep.
Where do you stand with shoes, like elevated for patellofemoral pain? If they have like an elevated heel, that's gonna be more patellofemoral pain than like a flat shoe. Is that accurate? Is that something that you pay attention to or not?
No, yeah, yeah. I mean, it definitely makes a difference. So we see that patellofemoral joint loads go down if you're running in a minimalist shoe. So, but of course, Achilles tendon forces are going to go up, and the opposite is true too. So, if you have Achilles tendinopathy, one of the easiest things you can do is run in some sort of high drop shoe. So that's going to reduce your Achilles tendon forces by about 10% versus a level shoe. But know that those loads are going to go somewhere and they're going to go up to your patellofemoral joint. And so, yeah, again, you're just kind of shifting these loads around. I mean, essentially with shoes, I mean, shoes are kind of fascinating. And I think like, I don't know, people tend to get a little bit passionate about them. And I don't always understand why. I think it came from like that book Born to Run. And it's become like this for some people, it's become like almost like a value system, like what kind of shoes they're running in. But for me, I don't know. I just tend to be very agnostic about shoes. I'm like, look, shoes are, I don't know, like an exoskeleton for your foot, if you will. So it's just shifting loads around within your foot. It's just like an exoskeleton that people might wear. Like if they're lifting something heavy, you'll start seeing more and more. Like the military starting to use this now for carrying heavy loads, or if you work in some sort of industry, you might have some sort of like a back exoskeleton kind of thing. I mean, shoes are the same thing. They're basically just distributing forces away from your foot, particularly if you've got a higher heel. And so, yeah, so that's certainly one way to do it. But again, if you were one of those people who read Born to Run and decide to run in a minimalist shoe, you know that you are shifting your loads around because you probably got very sore in your plantar flexors. And in some cases, we saw a lot of patients who develop metatarsal bone stress injuries or plantar heel pain or plantar fasciopathy, whatever you want to call it. So yeah, shoes can make a big difference, but for me, I tend to see changing shoes as being a relatively big change for someone, and so I don't know, I tend not to mess with that a whole lot. I would say that that's one of the things that unless they have a true foot and ankle injury, I tend to stay away from making much change. Change there. But yeah, going back to the 4-foot strike, I still see it a lot. I see it a lot in some high school runners, like their high school coaches. Everybody's very well intentioned, and so it's no one's trying to cause harm here, but someone's adopted like a 4-foot strike and they've developed some sort of foot and ankle injury. And one of the things that we know that high schoolers are very prone to is medial tibial stress syndrome, what I think a lot of people call shin splints. And there are lots of different kind of ideas on why we get that, but the predominant one is that it ends up being too much forces from your plantar flexors on your periosteum, that's just this connective tissue around your bone. And so if you're going to increase your load on your plantar flexors, one of the easiest ways to do that is to adopt this 4-foot strike pattern. So it's not surprising that we see a lot of medial tibial stress syndrome in runners who have adopted this 4-foot strike pattern. And again, we see that a lot of times happen in high school because we have, again, well-meaning, well-intentioned high school coaches that are saying, hey, I think you should consider adopting a 4-foot strike because, well, Kipchoge runs with like a 4-foot strike. And because he's the fastest runner, holds the world, until recently, the world record for the marathon, and it's certainly the only person ever to go under 2 hours. If he runs like that, you should run like that too. And that's not really, of course, how running performance works. So when you look at the evidence, it's really quite clear that running with a 4-foot strike does not reduce your risk of a running related injury. You're just choosing to get a different injury. So you're going to get a foot and ankle injury instead of a knee injury. Running with a 4-foot strike does not improve your running economy, and your running economy is the metabolic cost of running. And running with a 4-foot strike also does not magically make you a faster runner. You're certainly not going to break 2 hours right away for a marathon if you adopt a 4-foot strike. But as you said, you're going to get very sore calves.
Yeah. Yeah. Last thing on patellofemoral pain. I wanted to start on the bone stress things, but
Yeah.
this we state on this. You work with military population.
Mhm.
They get because they gotta jog and move with heavy weights on their back. How does that change things in rehab or even the likelihood of like their patellofemoral pain?
Yeah. To be clear, I do a lot of defense funded work from a research standpoint, but I actually don't work with the military too often, like directly. I mean, I will later this year, go on a couple different bases to work with soldiers. But well, I think it's really worth like going back and taking a look at what your knee actually does, what your quadriceps do. So when you run and when you walk, your quadriceps actually do not contribute a whole lot to forward momentum. Your musculature that gets you moving forward are your plantar flexors. Those are far and away, particularly with walking. I mean, your plantar flexors really contribute to both vertical support, but also forward momentum. And so, when we look at the knee, though, the knee is predominantly, our quadriceps are predominantly being used to slow down our center of mass as we're moving forward. And that's why when you go downhill or go down steps, you're slowing your center of mass as it's moving forward. So it's controlling the braking forces. And that's why going downhill or downstairs can be really provocative to someone who has patellofemoral pain. Now, the reason why I'm kind of going through all that is because when you run and you've got load on your back or you're rucking with loads, which a lot of people are now starting to do from a conditioning standpoint, and something I do, I really like doing it quite a bit. But you have to be very mindful of those braking forces. And so the braking forces are really important because if you take a really long stride, for instance, and you've got a heavy load on your back, what's happening there is that your braking forces are going to go up and those loads are going to be absorbed predominantly through your knee, through your patellofemoral joint. And that's really important for an athlete or for a soldier who is shorter in stature, who doesn't have legs that are quite as long, and they tried to take a longer stride to match strides with like taller cadets or taller soldiers. Those people often end up being female soldiers, but not all the time, of course. So we see that, and then also if you're a soldier and you're rucking, one of the things that will happen is when you can't run with the load anymore, you kind of do this walk, they call it wogging, which is, just taking a really long stride when they're trying to go as fast. And that really dramatically increases the loads on your patellofemoral joint. So we published a paper a couple years ago. We published it in Military Medicine where we had people walk with different stride lengths with different levels of load. And one of the things we found is that when you add more load to a pack, it increases the loads on your Achilles tendon. I think the ratio is 1 to 6. So every 1 pound you add to a pack increases Achilles tendon forces by 6 pounds. So it's quite a bit. So it's a really big relationship there. But when you look at the patellofemoral joint, it's almost a 1-to-1 relationship. A relationship. I think it's for every 1 pound you add to your pack, and increases patellofemoral joint loads by 1.4 pounds. However, if you take a long stride, meaning you're taking like a 10% stride or 10% longer stride, that relationship changes quite a bit. And so for every 1 pound you add to a pack, it increases loads on your patellofemoral joint by 4 to maybe even 6 pounds. So that can really, so if you're a shorter soldier, you should be very mindful about just using your own step length when you're carrying loads. And there are a lot of things you can do too. Of course, getting before you show up for basic combat training, one of the most important things you can do is get yourself on a heavy strengthening program. Particularly focusing on your hip extensors, your quadriceps, and your plantar flexors.
Hmm. Yeah. So all these cases of patellofemoral that you see, you think it's pretty much as simple as a training error, and it just manifested as in the patellofemoral joint.
Yeah, I don't think that there's a lot of evidence that would suggest otherwise. I mean, there's no biomechanics does not seem to predict who's going to develop patellofemoral pain. I would say that, yeah, I think it's basically a training load error. Now, we see that females tend to be at greater risk for patellofemoral pain. We don't necessarily know why. And again, we should be really careful about our biases. It's easy to say, well, it's because females have wider pelvises or it's because they have a higher Q angle or what have you. But the other thing too is another major risk factor for the development of patellofemoral pain is sport specialization. And sport specialization increases your risk of patellofemoral, almost doubles your risk of developing patellofemoral pain. And when you think about high school athletes, the athletes who tend to be pushed into specializing earlier are female athletes. And so female athletes tend to get pushed into just dedicating themselves to running, for instance, because they're going to run cross country and track. Maybe they're going to specialize in basketball versus the average high school male athlete will do, football or cross country in the fall, basketball in the winter, and then I don't know, baseball, soccer, or something like that, or track, in the spring. And so the male high school athlete tends to sample more sports than female the high school female athlete does, and I think that so there might be some real socioeconomic reasons why females tend to get patellofemoral pain more often than males do. We shouldn't always necessarily think it's because I don't know, because of their structure or something along those lines. So, and again, I'll go back to that biomechanic that you see a lot of times. You're like, yeah, but I see people who have patellofemoral pain, and I see their knee dive in so much. Well, if you've ever had knee pain, the last thing you want to do is bend your knee. So when you go down steps, you want to bend your knee. And if your knee hurts, you're not going to want to. And so, but you still have to get your foot down. You still have to get down to the next step. And if you're not going to bend your knee, you're going to get that motion from another joint. And you're going to get that motion from your hip joint. Typically, you're going to drop your pelvis and you're going to let that knee kind of dive in a little bit. And that motion is all coming from your hip. And really what that is, it's probably a very painful knee, or it's a quadricep that is not strong enough to tolerate the loads that you're doing. And so when we see people that are recovering from anterior cruciate ligament reconstructions, that's actually a pattern that we see with them a lot. They will suddenly start developing a lot of people call it knee valgus or like this medial knee drift or what have you. And you're like, we need to do a lot of hip strengthening with that person, but it's actually the exact opposite. Sure, a lot of times you might be like thinking, okay, yeah, I might need to be doing some sort of hip strength. This person has an anterior cruciate ligament reconstruction, that's fine. But really what you need to be doing is more quad strengthening with them because they don't have the capacity to control their center mass when they're stepping down or when they're running or doing a lunge or a squat. And instead they're throwing their hips into it a lot. And in fact, most of the patients that we see who come into our lab who are post ACL reconstruction, we're talking 30, 40% strength deficits in their quadriceps, but their hip, particularly hip extensors and hip abductors are actually stronger than their age matched and activity matched peers. And you even see that on a side to side standpoint. You see that their hip will be a lot stronger in someone who has an ACL reconstruction on that side versus their contralateral limb.
Really? Wow. Yeah. Okay, we could keep going on patellofemoral, but we're gonna run out of time. Let's go on to the bone stress. I guess before yesterday, you kind of told me that's kind of your newer thing you're looking into, bone stress injuries, and I didn't have too much curiosity, but I listened to a couple of your episodes, and I was like, this is actually really fascinating because of my thing with the tendons. It's like there's so much work that I have read on muscle and tendon and hardly any on bone. But it's been a thing where I'm like, there has to be some connection. Um, yeah, there has to be some connection there of like maybe understanding bones could help people understand tendons better. But anyways, let's not try to go there immediately. For you, bone stress injuries, like for someone that doesn't know about them, what exactly is going on?
Yeah, yeah. I mean, it's essentially so we're always turning tissue over, and whether it be tendon, muscle, or bone, and obviously muscle turns over the fastest, and tendon's going to turn over probably the slowest of those three. And what is driving that rate of tissue turnover is mechanical loading. And so the mechanical loading is going to be driving this. And so and it's very much cell mediated, meaning the cells are in control. In the case of tendon, it's your tenocytes, tenoblasts. In your bone is your osteoblasts and osteoclasts. Osteoclasts break down bone, and osteoblasts lay down new bone. So I think when most people think about stress fractures, they think about this person who is a runner, who maybe perhaps, a lot of times we kind of stereotypically, and I certainly did, think about someone who is maybe a little bit underweight, who is, and we started thinking, well, this person is developing this bone stress injury because they're running so much. It's a repetitive load issue. But we're really starting to understand bone stress injuries a lot better. And I would say that that's not really the case. So I think what we can do is we can kind of divide these bone stress injuries up. And the reason why I'm using this term bone stress injuries is because we've really have moved to adopt this term because that encompasses bone stress reactions, which is a precursor to a true stress fracture. You don't truly have a bone stress fracture until you have disruption of the cortex of the bone, and which is the outside part of the bone. So we've kind of used this umbrella term as the bone stress injury because what was happening was a lot of people were like, oh, I don't have a stress fracture, I just have a stress reaction. I'm going to keep running on this thing. And of course, if you keep running on a stress reaction, it will develop into a true stress fracture. And so using that term, I think, has been very helpful with helping people understand the seriousness of the injury that they're dealing with. And when you think about bone stress injuries, really there are essentially two different polar opposites of why someone might develop a bone stress injury. One is this athlete who is really underfueling, this athlete who is in some sort of low energy availability, and so the term you hear a lot is relative energy deficiency in sport, which originally got its start in female athletes. It started off in 1994, was first coined as the female athlete triad. It has evolved until in 2014, the International Olympic Committee came out with this term relative energy deficiency in sport, which it does encompass components of the female athlete triad. But of course, now the female part is not part of relative energy deficiency in sport because now it's well recognized that males also are very prone to low energy availability or underfueling. So on the one hand, we have that. And so I think you can kind of think about your endurance athlete who is going to be getting that. So we're talking about, runners, I think is a classic example. Then on the other end, you have your athlete who is under a lot of biomechanical loads, and so really cool study came out of Stanford a couple years ago. Adam Tenforte is a close friend and collaborator, was one of the lead authors on that paper. They looked at I'm guessing it was a Stanford basketball team over a couple of seasons, and they took they took these MRIs, prospective MRIs of their feet before basketball season started. It's a brilliant study. And then they followed them throughout the entire season. And then they did these MRIs again at the end of the season. And so after, what is it? I don't know, 35, 36 games in an NCAA Division I season, they looked at these athletes' feet, and they found that almost all of them had some bony edema in their metatarsals. Some of them had some bony edema in their sesamoids, and also in some of their cuboids, which are some of your smaller tarsal bones in your feet. And so that's going to be a case where you're basically topping out at the body's ability to adapt to the applied loads that are being applied to it. And so you've got these two polar opposites. You've got an athlete who is underfueling, whose physiology is not able to adapt. And then you've got an athlete who is probably feeling okay because we know that relative energy deficiency in sport is not super common in basketball players, but they're undergoing huge biomechanical loads, and you're really topping out at your physiology's ability to adapt to loads. And so while it's easy to, of course, we don't really think about this, particularly when we're young, is that we often think that like there's no physiological cap to my ability to adapt in the gym, but we all know that that's not really the case. And bone, we tend to hit that ceiling pretty quick. And I think how we train bone to be stronger, it's really important to understand how bone adapts to loads versus muscle versus tendon, because you really can develop a bone loading program that's very specific to bone. And you want to really be thinking about doing that for your athletes who are at high risk for bone stress injuries, because you can have a pretty measurable effect on their risk profile for developing some sort of bone stress injury. And again, you have to have enough adequate fuel, because if your no amount of exercise is going to I don't know what maybe a better way to put this. You cannot treat too much exercise with more exercise, if that makes sense. You gotta make sure that the physiological processes are in place to support overall bone health.
Why do you think that is, the not having enough nutrition coming in? Why is that leading to more, the bone just can't, it's not giving the resources for a bone to recover? Like the nutrition aspect for me, I maybe it's the understanding of bones. I've always been like kind of neglect. Who cares about bones? Probably most people do. But like muscle, we know we need protein and glycogen, we need to recover muscles. What are the processes that are recovering a bone in terms of the nutrition?
Yeah, that's a great question. We could have a whole podcast on that, and honestly, it's a little bit outside of my area of expertise, but I'll tell you what I know, and that's that the bone, we can kind of divide it up into kind of a systemic energy availability, but also localized energy availability for the bone. So the bone itself, the bone is highly vascularized. Anytime you see blood vessels, you know that there's a lot of metabolic activity that's going on there. And so we have different types of bone. We have cortical bone, which is the hard outside bone that we see like on your outside of your femur, for instance. And then we have your trabecular bone, which is the spongy type bone. And we see that inside all of our bones, and some of our bones are very trabecular rich. So the sacrum, for instance, there's a lot of spongy bone there. Our femoral neck, there's a lot of spongy bone. Lumbar vertebrae, for instance, also a lot of spongy or trabecular bone. So that trabecular bone is highly energy intensive, meaning it requires a lot of energy to exist and for the metabolic activities that it's doing. So we have a lot of things going on there, like a bone marrow, for instance. I mean, that's where all that stuff's happening. And so when we see these athletes who get a more proximal, of course, notice all those bones I just mentioned, femoral neck, sacrum, lumbar, they're all proximal. They're all around the pelvis. When we see an athlete who has a bone stress injury in that region, you should have full stop thinking about biomechanics, stop thinking about anything other than the fact that this is an athlete who has been under fueling and probably in a very persistent manner. So if someone comes in, they have a sacral bone stress injury, but don't start thinking that they've done something. They need to have a gait analysis, because you're wasting a lot of time. The most important thing for them to do is to get screened for relative energy deficiency in sport, and there's some really effective screening tools that are out there. So there's that energy component. Now the other part too is that bone is really, and this is a part that is a really rapidly evolving science, and that's that bone cares a lot about where your calories are coming from. So, and we all know this. If you've ever tried going on like a low carb diet, or you've done some like intermittent fasting, you know that you get some brain fog in the morning. You can't think as well, and that's because your central nervous system pretty much relies on glucose. And when you're fasted or you're not consuming a lot of carbohydrates, your glucose levels, tend to go down, and your bone actually is also very carb dependent as well. The problem is your bones don't tell you when they're foggy, or you can't think very well or concentrate like our brains can. And so instead, what happens is that athletes who are training in a very fasted manner, who are also burning a lot of calories. So runners, for instance, who wake up in the morning and go for long runs and then are avoiding using some sort of supplemental nutrition in their runs, they get themselves in this big acute state of energy deficit. And there's some evidence that is starting to show that really accelerates not only the rate of that our osteoclasts are being active, so it actually increases the amount that are breaking down bones, but it actually shuts down our osteoblasts as well. So the osteoblasts are going to be the ones that are going to build new bone. So again, it accelerates bone breakdown, but it actually kind of essentially decelerates the amount that we're going to be replacing that bone. So that's a really very quick and easy way to get yourself a bone stress injury, is to go on a low fat diet while you're training for a marathon.
Low carb, you mean?
Yeah,
Yeah.
sorry, low carb diet. So these paleo diets, what have you. It's a really easy way, and you can see it a lot in in triathlon, for instance. There's been some really high profile sacral and femoral neck bone stress injuries that have occurred, and some of their top level pros in that sport who took on this, who made some big change in how they're eating, and essentially what they're doing is they're doing some sort of carbohydrate restriction. And so the other time you might see this too, and I'm not a registered dietitian, so I really recommend speaking to a registered dietitian. But what I do is I do screen for people who need to go see a registered dietitian. I've got some really excellent ones that I work with, some local and some that I refer out via telemedicine. And so but these are individuals who have expertise have expertise in treating people who are dealing with relative energy deficiency in sport. And so, but what the other one you see a lot are the athlete who is a vegan athlete. And there's nothing wrong with being vegan, as long as, and again, I think if you're training at a high level and you're a vegan, you should at least get a consultation with a sports RD. The big reason for that is that you're consuming a lot of plant products, which tend to be very high in fiber, and fiber fills you up. And because of that, you don't end up consuming a lot of carbohydrate. And so we get a lot of our carbohydrates from, frankly, pastas and other activities. And of course, there are other ways to get carbohydrate as well. But anytime I hear an athlete that is coming in and sees me with a bone stress injury, who is then doing any sort of dietary restriction, I immediately start thinking, I think you might benefit from seeing a registered dietitian. I've got a couple that I work with. Let me go ahead and get you set up. And a lot of times I have to kind of do some convincing to get him to go. And I'm like, no, I think this would be really helpful. And if you want to really recover from this bone stress injury quickly, I think you're going to need to make sure that you're checking all your boxes. And the reason why I say that is because, look, I can treat patellar tendinopathy or Achilles tendinopathy by myself. I can treat patellofemoral pain by myself, but there's no more complex injury that I treat than a bone stress injury. When I treat someone who has a bone stress injury, I'm always thinking about referring them out to a sports RD. I'm working with their sports medicine physician. I'm often corresponding very closely with their sports medicine physician because there might be, and of course, we're talking about this athlete's physiology. And also the coach. The athlete's obviously very important, and also for the younger athlete, their families are really important as well. And so, one of the things we see a lot in high school athletes is we see maybe parents who have they've decided to go on these low carb diets, and then of course they adopt it in their household. But their kids are continuing to run high school level, and also at a high level. I mean, where I live here, this is a big endurance mecca, and we see it's not unusual for us to see high school runners running 40 to 60 miles a week. And then, someone in their household is, adopted this low carb diet, and then they get a bone stress injury. So we see that, we really see that quite a bit. But the other thing too that happens from to your question about, so that's the local part of it, and the global part I know less of, and so I'll just be kind of quick about that, and that's that it really affects your hypothalamic pituitary axes, and we tend to it really reduces our hormone levels. And so, bone is highly estrogen sensitive and progesterone sensitive. It's also very testosterone sensitive and as well. And so, one of the things that reduces a lot when we're under fueling are all three of those hormones. And so, it manifests itself quite visibly or noticeably in the female athlete by a cessation of a regular menstrual cycle. In males, it's a little bit less obvious. They might be the high school male athlete might begin shaving later, so they might not develop facial hair later. Lower sex drive, frankly, lower, less frequent or absent morning erections in males because their testosterone levels are lower. And know that if you start to see that, what's happening there is your athlete is also not recovering as well from really high energy or high intensity exercise bouts, but also they're going to not have adequate bone health. And we see that athletes who have low testosterone in males and female athletes who do not have a regular menstrual cycle, they have a dramatically greater risk of developing a bone stress injury. And we also see more trabecular bone stress injuries in that group, and we also see more high risk, what we call high risk bone stress injuries, and those are the ones that often need or require surgery
Mm.
for adequate treatment.
All those proximal issues. Um, I think your past episode podcast, you were talking about the more distal issues, and that being more about was it more about the biomechanics?
Yep. Yeah.
Yeah. So yeah, could you get into, I guess, the differences there? Why is that the case?
Yeah, so we can think about like maybe like a basketball player would be a good example. So, when we look at basketball players, they often get metatarsal bone stress injuries. They're high risk for navicular bone stress injuries and also tibial bone stress injuries. And so, a good rule of thumb is the closer you get to the ground, the more biomechanics is going to matter. The further you get away from the ground, meaning more proximal, the more you need to be thinking more about systemic issues. That doesn't mean that systemic issues, like we were just talking about, you don't see that in athletes who get these distal bone stress injuries. But when I'm looking at someone as a fifth metatarsal or a second metatarsal bone stress injury, I'm always going to be thinking more about biomechanics. And so, and again, we'll go back to that example of the basketball players across several seasons. When you see that their bone marrow edema will start to increase, and of course, they'll stop playing basketball for a little bit, and the bone marrow edema will go away, and then they'll start their next season. And they'll probably repeat that cycle all over again. What we see is we used to, and this is you still see us a lot, and I've been working really hard, and others have been too. And we have some papers coming out looking at this. We used to think that loads on bones had to do with impact forces. So you think, oh, well, that person, you can hear them coming a mile away, and so they're hitting the ground very hard, and so of course they're getting a lot of loads to their bones. That's not actually the case at all. And so we'll just use our tibia as an example. When we run, we all know, I'm sure you've talked about a lot on your show, that Achilles tendon forces during running, even just recreational running, end up being 6.5, 7 body weights of Achilles tendon force. Well, when we look at our tibial bone forces end up being around 9 to 10 body weights. And so when you look at your vertical ground reaction force when we run, it's usually end up being about 2 to 2.5 body weights. So we've got this tibia that's getting 9 to 10 body weights of compressive force on it, but we only got 2.5 body weights of vertical ground reaction force being applied to it. So you've got 7.5 body weights that are missing, and those 7.5 body weights are coming from your plantar flexors. And so muscle is far and away the biggest contributor to bone forces. And again, for our tibia, we see that that ratio is about out of 10, out of like say 10 body weights, 8 body weights is coming from your plantar flexors. And so we think a lot about how can we control plantar flexor loads when we're helping someone get back after a tibial bone stress injury. And then also the other part of it too is, making sure that when we're doing the rehab for someone, we're applying a lot of plantar flexor loads to that person's tibia so we can condition the tibia so we can regain the bone strength that it needs so it can go back to sport. And so again, it always comes back to load capacity and how can we in our rehab replicate as close as we can the loads that this person needs to prepare themselves to return to so that they can have hopefully a healthy and durable return to sport. And, going back, I don't know, like when I think about how we treat bone stress injuries now, it's very analogous to how we treated ACL reconstructions, I don't know, in the early 2000s by doing a bunch of straight leg raises after someone has an ACL reconstruction, and then sending them back to play basketball after just doing some straight leg raises and I don't know, maybe some body weight squats, and then being so surprised when they re-rupture their ACL or tear their opposite ACL. And so a collaborator of mine, Dr. Christy Pop, she's an excellent exercise physiologist. She published a study that really kind of made my eyes open on this. And that's that she followed people after tibial bone stress injury. She followed them for a year. And Adam 10 is another researcher on that project. And this is when she was at Harvard. And they did repeat DEXA scans on these folks as they were recovering from these bone stress injuries. And what they found was that their bone density dropped in the first 16 weeks after a bone stress injury. And it took almost a full year to recover this person's bone density after they experienced a bone stress injury. Now, what's really remarkable about that is a couple things. First, you saw that decline in bone density, not just in the leg that was injured, but also on the opposite limb as well. So they're globally reducing the amount of loads on the system. And then, not surprisingly, 1 out of 3 people in that study had a recurrent bone stress injury within the first year. So what this is telling you is that we're probably really undertreating these people after any sort of bone stress injury. We're probably pulling back on the reins too much. We probably need to be a lot smarter about progressively loading them. We probably need to start doing a lot earlier than we used to. And so Stu Warden, Brent Edwards and I, we all kind of do some stuff in bone, but I would say Stu in particular, and also Brent do more bone work than I do. But for me, from a clinical standpoint, we wrote this paper, or actually a couple papers 2 years ago, and we kind of laid out in there essentially how I treat people after a bone stress injury. We start loading them very early after a bone stress injury. We start doing early plantar flexor strengthening. And we also start thinking about how can we get this person back to activity a little bit low, or basically a little bit easier, but also can we do it and reduce their plantar flexor loads, at least in the temporary basis, and then slowly add them back in so we can get them back and more active earlier with the idea, hopefully, that we can reduce some of this loss of bone that is occurring in the first 16 weeks.
Um, the so I gotta you said earlier about the like maybe the time windows of loading, and I was aware through Keith Barr had this lecture talking about the refractory period of the tendon, at least in the petri dish studies he was doing. And I think there was that study on bone where they did like the 10-minute loading and then the hours of like rest in between. Is that the same mechanism of like you do a little bit, so like you're signaling the synthesis of bone, but you're not getting too much degradation, and then you're repeating? Is that like the same idea there? Uh, for how you would, is that something you do?
Yeah, exactly. Yeah, same concept. And I think Joe Cook has a really good take on this, and that's that the more collagen in a structure, the quicker it's going to get desensitized to load. And so we see a lot of collagen in tendon, and we see a lot of collagen in bone also. And so we see that bone starts to lose its sensitivity to loading after about 60 to 90 loading cycles. And so whenever I'm working with someone who's got a bone stress injury, rather than doing, I don't know, like, I don't know, 3 exercise sessions a week that I might do with someone who has like a tendinopathy, what I'll do is we'll actually do several loading bouts during the day. We just separate them out by 4 to 6 hours. And so, now, of course, if that person has, available time. And so a really great example of that would be someone like an NBA player. So they wake up in the morning, they're recovering from a bone stress injury, might have them do, like 3 sets of 45 counter movement jumps. They'll hang out. They'll come in to the facility at lunch. Around lunchtime, they'll go out. They'll do some more jumping, maybe 45 repetitions of that. Do some other activities that are specific to their injury, and then also some global conditioning activities. And then they'll go home, and then that evening they'll also do another set of jumps then as well. So the idea is you really want to be splitting these loading bouts up by about 4 hours, so you can restore some of this mechanosensitivity to the bone.
And that would be like early on type thing, right? Because like I'm thinking like later on as if this is wrong, correct me, but like early on that you could do something like that. Maybe it's lower intensity, and then later on, as they like are reaching, they're doing sessions at like their max effort. That would probably be hard to repeat every like 5 hours. Or is that not the? Yeah,
No, 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 no. Yeah, no. I think you're thinking about it the right way. Yeah, exactly. So in the early stages, it's really important. You want to have some very short, very intense loading bouts, and then some time when you're doing something that is not osteogenic for them. Now that's going to change over time. So in the early stages after bone stress injury, there's a lot of things that are going to be osteogenic. But once that person is getting into the later stages, like for instance, like right now, I'm working with a basketball player. He's recovering from an anterior cortex tibial bone stress injury. We're doing some very focused hopping. So we always do the most intense activity at the very beginning of the session. So he's doing some hopping at the very beginning of the session, and then after that, we start doing some things that are going to be easier on the bone than that. So things like spot shooting or some other activities that are not going to be putting a lot of bone loads there. So I would continue. So that what's going to be osteogenic for an athlete is going to be different next week than it is today, as that athlete continues to build more and more bone strength. So, but knowing that can be really, really helpful for a lot of different athletes. Knowing that bone responds to very, very high loads that are applied very, very quickly and very, very short bouts. And the reason, when you think about that, a load that's applied very quickly, that has very high load, you should immediately start thinking about plyometrics. And plyometrics are a really cool activity. And the big reason why plyometrics are so cool is because, first off, they don't require a lot of equipment. And the other thing too is when we think about the endurance athlete is they don't require a lot of energy. Strength training does require a lot of energy. And so if I have a high school athlete, for instance, who I'm a little bit nervous about under fueling, one of the best things I can do with them is, instead of putting them on like a heavy strength training program, is put them on a plyometric program. And so when high school coaches come and talk to me about, hey, what can we do to improve the resiliency of our team? We're starting to get some bone stress injuries. The first thing I always say is, let's get them on a plyometric program, because the energy demand of doing plyometrics, because of course you're tapping into the passive energy storage or release capacity of your tendons. Doesn't take a lot of energy to do your plyometrics, but you can get a really nice load on the bone. And you're going to be able to drive a lot of really nice bony adaptation as well. Strength training is awesome. So don't get me wrong. I think strength training is the best for a lot of activities, particularly for muscle and tendon. But for bone, some sort of plyometric is going to matter. And so how you do this plyometrics matters a lot too. We know that, for instance, if you want to get a lot of load on the foot and ankle, you need to have very short contact times. So encourage your athlete to get off the ground very quickly. If you want to get a lot, like a lot of loads on the femur, you want to have longer contact time. So for them, I tend to cue them a little bit softer. If you want to get a lot of loads on the femoral neck, we know that a bilateral stance is, so landing on both legs, does not bend and twist that femoral neck very much. You need to do a lot of single leg landing, single leg side to side hops, because it's going to bend and twist that person's femoral neck a lot. For the lumbar spine, one of the most important exercises you can be doing for the lumbar spine, because as you get further and further up the chain, the load is going to get filtered out, or the muscle forces are going to be less and less. By the time you get to lumbar spine, you don't have, our back extensors not as big as, for instance, our quadriceps or our plantar flexors. You need to be a lot craftier about it. And so what I'll do with those athletes is we'll do deadlifts, but probably one of the best things are back squats and you want to do his back squats kind of fast. So you want to, lower down kind of slow, just like you would for if you're doing some sort of like a tendon loading program. So lower down 2, 3 seconds, and then you want to really explode up, almost like you're training for power, because the faster you can load that person, the greater the strain rate is on the bone. And strain, like bone is most sensitive to high strain rate. And as you know, I know because I've listened to this podcast several times, the tendon is most sensitive to higher strain values. So strain, of course, is change in resting length. Strain rate is basically the speed that you're trying to stretch a bone, or stretch any sort of structure. And bone doesn't respond well to heavy, slow resistance training. It responds the best to heavy, fast resistance training. And that's again where the plyometrics come in.
Yeah, that makes me think of that first part you said. If you got like a um 10 times body weight when you're running, and then it's like whatever 7 of that was coming from the Achilles or the muscle, is like if you're in the weight room doing a calf raise, you would have to lift such a significant load to get the strain on the bone. That would be like nearly impossible, right? That's just if you do it a plyometric, it's so much easier.
It's so
Um,
much easier. Yep.
yeah, yeah.
Yeah. Now,
So
I mean,
go
just
ahead.
to back up though, with rehab after a bone stress injury, you can't do the plyometrics early on. And so let's say they're in a walking boot. So knowing that, you don't want to say, oh, I don't want to do heavy, slow resist or like resistance training on the plantar flexors. But what that does tell you is that you actually do. You want to do it in the early stages of rehab after a bone stress injury, because it is going to be a load that's going to be less than perhaps even walking. It's going to be a load that's going to be less than running, certainly. And so maybe what you want to be thinking about doing is doing some really heavy resistance training leading up to the time when you start running. And you can even start doing maybe some band assisted hopping. It's like using one of those like pull up assist bands. Those are going to be some really great ways that you can start kind of gradually and in a very progressive and incremental manner, getting more and more load onto his athlete system. I'm sorry, I didn't mean to interrupt you earlier, but I just wanted to kind of make sure that people didn't automatically start thinking they needed to do like plyometrics with their athletes who are 3 weeks out from a bone stress injury, because you're going to get yourself in a lot of trouble if you do that.
Yeah. Um, so like maybe this is outside of that idea of like the short loading, and then the quick recovery thing, because when we get to the like if the tendon is the same way, and like early on in tendons you have that whole like you can do isometrics 4 times a day to like get load in the tendon. And probably I never know, Joe Cook said that with the more collagen, the faster the refractory happens.
Mhm.
That's interesting. But later on, I'm thinking of that tendon graph on collagen synthesis and degradation, and they use like those 3 really intense studies where they saw you need like a 48 to 72 hour basically rest period of intense loading before the tendon regenerates, or before you get the net collagen synthesis. When you're talking about really intense things like sport with bone, is there a similar thing happening where you need a long period of time, or is that not the case?
Yeah, no, not really, and I'm not entirely sure why that is. It does seem to be, and of course, a lot of this is kind of being driven out of from some animal models. I mean, like all things, tendon and bone. I mean, you can't be doing like biopsies on bone necessarily, like in someone it's going to be hard to get that through some sort of IRB. But this has been translated then into some bone loading programs, and where they're doing multiple loading sessions per day. And it does seem that when you do that, that does seem to give you, the more, unlike tendon, where you, like you said, you do need to have a recovery period where you kind of, because you have this collagen degradation, period, and then it takes a while for the collagen synthesis lags behind a little bit. Bone seems to be able to respond a little better. And so when you look at the plyometric studies, it seems like the more sessions you do in a week, the greater the bone adaptation is going to be. So again, what you want to do is you want to have low volume, high intensity sessions, but you want to do them fairly frequently, and that seems like that's going to drive the most adaptation. And so, yeah, like what you said, I used to treat tendon and bone very similar. I used to be like, oh, we only want to do our loading exercises 3 times per week, and are you going to get some adaptation with that? 100% you will. But if you really want to get the most load or the most adaptation, you want to do it more frequently. And for a lot of athletes, particularly the professional athletes I work with, I mean, dollars are days. And so they need to get back as quickly as they can. So yeah, more frequent is typically going to be better for them.
How do you look at So we talk about that plyometric load being giving the strain to the bone that you need to adapt. How do you look at like swimming, cycling? Are those basically doing nothing for bone?
Yeah, they're doing nothing. Yeah, nothing at all. You know, in fact, so when astronauts train to go into outer space, they train in a swimming pool. And so when you're in a pool and you're speaking to like a former swimmer, and I swam and played water polo in college, and you know, when you're doing that, it's not that you're like I wouldn't necessarily say that like you're losing bone, but you're certainly not doing a bone building activity. And so someone recovering from a bone stress injury, they'll like, oh, we'll get them in the pool. We'll start doing lots of pool therapy with them. Well, that's great for their conditioning. That is going to do nothing for their recovery from this injury. Now, with that said, though, it can be very helpful. And so, by the way, cyclists too. So if you want to see poor bone health, look at elite level cyclists in their 20s, and they typically have the bone health of a 65-year-old. And there are lots of reasons for that. A big one being that they are doing a non-weight bearing sport, but also because cycling because you don't typically have a lot of the musculoskeletal wear and tear, you can train for really long hours. And so you can really burn a lot of calories, but you also don't get very much biomechanical loads on your bone. And so when you look at the average person who has a bone stress injury versus someone who has, again, patellofemoral pain, this is really great contrast. The average person with patellofemoral pain is going to really diminish the amount of activity that they do. They're going to really kind of pull back and spend more time watching Netflix, hang out on their couch more. The person, and this has been a really cool study that's published, and I should do a post on our Instagram page about this. People with bone stress injuries don't do that. And when you look at activity monitor data on people who have a bone stress injury, you almost can't even tell that they have a bone stress injury from before when they had it before. They will they will stay as active, and so they will get that caloric burn one way or another. And so the reason why I say that is because for someone, again, this I'm thinking a lot about some of the endurance athletes that I work with. The biggest issue I have is keeping the reins pretty tight on the amount of cross training they're doing, because if they're continue to keep themselves in a state of low energy availability, they're not going to have the available, um, I don't know, energy as well as this physiology that's going to support their healing and is going to delay their recovery from this injury. And so it's going to be something that I really want to keep very very close tabs on. Now, with that said, I think about like the high level athlete who's experiencing high level. We need to get them back to you're really experiencing high level loads. And again, basketball is. I love working with professional basketball because they're. I mean, running frankly is kind of is. I mean, don't tell any runners this, but it's a little bit boring in that it's the same step one after another. Every step is almost the same. Even when you go uphill, it's a little bit different, but it's still the same. Like we're very much there. It's very much a sagittal plane sport. Basketball and soccer and volleyball are not like that. And so you need to really, I think for me, it's been a really great professional growth opportunity for me to work in those sports because it's really helped me think long and hard about how we can progressively load these athletes and think about it. And so we really need to start thinking more multi-axes when it comes to loading those athletes. But you can do these very intense sessions, but then you can still go do a lot of conditioning stuff afterward. You can get them into like an alter G, which is actually not going to be very much load on the bone, or you can get them into like I know like pool therapy or get them on a stationary bike and they can knock themselves out on that. And it's not going to be a big deal. When they're doing that, the bone is going to be recovering that mechanosensitivity because the load on the bone is quite low when they're in the pool, when they're doing the cycling. And so it's not like you have to be like, all right, sweet, I did my 45 jumps. I'm out of here. I'll see I'll see you tonight, or I'll do my jumps before I go to bed. I promise. It doesn't work like that. You can still do a lot of other stuff. You can still get in the gym. You can still do strength training. You can still strength train like they're giving their plantar flexors because again, the load on the bone is quite a bit lower than doing those jumps.
Yeah. Is that do you look at tendon the same way if that 10-minute refractory happens from like a high strain thing? Like if you end of the session do something like really light loaded that's barely any strain, is it still getting that recovery? Like you're still
Ooh,
getting
that's a
that.
good question. I don't know that science as well.
Yeah. I don't
Yeah, I
I've
really wish
I've
I
really
did.
speculated on the whole tendon thing, like, myself because I'm like, I don't know, it just didn't completely make sense to me. Um, yeah,
Mhm.
but maybe let's not go down that. I'm curious on this, in the past, you were talking about delayed onset muscle soreness of, like, the muscles kinda telling you that it can't keep up with the pain, and then, I have speculated that I I think based on those UTC scans, I think it was the Australian football team, that they saw the tendon starting to have the degradation like at day 1 and day 2 after the thing, and then it recovered. And I'm like, I bet you DOMS and tendon are going together. Is the bone, do you think, experiencing the same thing with like, but maybe you don't necessarily feel it?
Yep. Yeah, and in fact, so muscle and bone are very synergistic, right? So muscle needs bone to have a firm attachment or anchor point, but it also uses bone as a leverage, as a lever, so it can exert, so it can move a joint. Um, Bone requires muscle because that's where it's getting all of its mechanical stimulus from. And so if you don't have muscle pulling and twisting and bending bone, and the bone is not going to adapt to it. And so there's this really important synergism that is occurring between muscle and bone, but we can say that muscle is synergistically dominant on bone. And that's that as muscle goes, bone will go. And so we see this, and the very extreme example would be what is now being termed as osteosarcopenia. And that is in the older adult who is developing sarcopenia, they're losing muscle mass, muscle function, muscle force capability. You also see that you almost always see loss of bone density and bone strength as well. But what we see there too is that from the athlete standpoint, we see that muscle is far more adaptable than bone is, and certainly more adaptable than our tendons. But as you mentioned, our bones are not going to be able to like really tell us what's going on and say, hey, like I'm really starting to accumulate a lot of micro damage here. And so a really good indication is if your athlete is continuing to have a lot of muscle soreness day after day, particularly in the early stages of like a training camp, or they report for, training, they're trying to make a roster, they're really dealing with a lot of muscle soreness. If their muscles are having a hard time keeping up with the load that you're throwing at them, you can count on the fact that their bones are going to have a really hard time of that as well. And so what you see is really quite clearly in lots of different sports, but I'll highlight two different ones. We see it in the military. We see the bone stress injuries peak in week 6 of basic combat training, and that's because that's when our bone micro damage has started to accumulate, and then our osteoclasts come in and they remove that bone, and so our bone mass is actually the lowest around week 4 through week 6. We see it very clearly in the NBA and their epidemiology data when it looks at bone stress injuries. Bone stress injuries peak around week 4 to week 6 in the NBA as well. And if you ever see an athlete who develops a bone stress injury in the first couple weeks of a new exercise program, so if you have an athlete, if you're working with NBA or WNBA or college athletes, and they get a bone stress injury in the first 2 weeks, you can feel confident that they actually got that bone stress injury before they showed up. So they were working really hard, they were gunning really hard to make roster, and they showed up and they were already in a state of where they had a bony disrepair state in whatever bone it was that they ended up getting this bone stress injury, and then loads went up, kept going up, and then they got this bone stress injury. So the bone stress injuries that people earn during an activity typically don't show up until week 4 or week 6. And so thinking about that a lot is really important, and but it's really hard to predict. And so you have to rely on how's this athlete's readiness every day? Are they getting a lot of soreness? And if so, you might want to think about programming in some, like a relative rest day. But the other thing too, you can also and this is really important for athletes who self-coach, because athletes who self-coach are frankly not very good at it for the most part. We tend to like get ourselves on programs. I mean, I'm following this program, or like, I need to run around the block to make sure I hit, my GPS watch tells me I'm hitting right on 10 miles for this run or something. The most important thing for those athletes to do is every third to fourth week is program in like a deloading week, where they're reducing their overall volume of training that they're doing and allowing their physiology to catch up with where they are. And that's also something I do too with athletes who are coming from a bone stress injury. Once we really start hitting these progressions really hard and we start ramping up these bone loading programs, every fourth week or so, I'm like, all right, we just need to pull back on the reins a little bit. It's okay to keep some intense activity in there, but what really will wear a bone down as far as accumulating micro damage is high loading that you're doing very repetitively. And so we still want to keep the high loading in there, but we'll just kind of ease up on the amount of volume that they're doing.
Do you I've had this thought with tendons on that whole high intensity, high volume, with the collagen synthesis degradation, if that's the thing that's gonna lead towards like a tendinopathy, or I guess tendon rupture injury. Do you think the volume is the big player there? If the volume is the big player, like you're taking a deload week for the bone and you just kinda, it sounds like you're just decreasing the volume to let it catch up. Do you think a similar thing is existing with tendons?
Yeah, that's a good question. I mean, I would say I would have a hard time believing that it isn't. Now, I should say it's not that it's the volume of high intensity loading, and so one of the I think one of the biggest mistakes people can make, and I certainly continue to try to think about this myself, is, well, first off, we don't really think very well on, most of us think on a linear scale, right? And this is why, like, when the pandemic happened, we couldn't fathom the idea that, like, suddenly in like 3 weeks or 6 weeks, like, everybody was going to have COVID, and that's because that spread on this exponential, scale. Well, bone and tendon are the kind of same way, and when it comes to damage. And so when we increase our loads, by, I don't know, like, say, like a whole body weight, we increase the load on a bone by a whole body weight. That's the load on the person, on that bone. But the effect that it has on micro damage, there's actually an exponential effect there. And so, there's a rule called the Palmgren minor rule when you look at, like, tissue loading. And so for bone, we basically raise it to the level, to a power of six. And so, and you can be a little simpler about it too. In other words, for every 10% increase in load on the bone, it increases or reduces the number of loading cycles that the bone can tolerate before it starts breaking down by 50%. Is a kind of a good way to think about it. The opposite is true too, and that's that for every 10% that you reduce the load on the bone, you can tolerate 50% more loading cycles before you start accumulating micro damage. And I know that kind of sounds like a little bit of a word salad, but I'll put some real world examples on that. First off, that's why running cadence is really, really helpful for the athlete who's recovering from a bone stress injury. We reduce loads on the tibia by about 10% when you run with a 5 to 10% higher cadence. And when we look at the amount of, so that's just going to reduce that tibial bone compressive force by 10%. But when we look at the risk of developing a bone stress injury, and there have been a couple really nice probabilistic studies that have looked at this, we look at about a 65 to 70% reduction in developing a bone stress injury. And so there's not this like one-to-one as far as relationship between reducing load and reducing risk of injury. It's actually much, much stronger than that. And then the second thing too is, like, when we think about like the NBA, and I know over the last several years, there's been a lot of like press about like player load and load management and all that stuff. And like, what is player load? And, there's a lot of, I think, really good discussions here and, about that. If you were to ask me, the only thing I would care about in a basketball player or a volleyball player, would be how many jumps they do in a game and how close they get to the basket. Because the closer you get to the basket, the more intense the basketball moves are going to be. You're going to be cutting and twisting, and you're going to be, doing like a cutting type layup, and that's going to be putting a lot of bending and twisting forces on a bone, and that's going to be the most stressful on it. The standing around time, the jogging up and down the court, those athletes are not really running very far at all. It's the jumps. And so a lot of times people are like thinking about using some sort of wearable sensor. What kind of wearable sensor can we do to monitor training load on someone? And now we're starting to see these accelerometers show up again. I say again because, they were really big back when I got my PhD. They kind of went away, and now they're much smaller. And now people are trying to embed them in shoes and stuff. And the reality of it is that the only thing that really matters is how many times you're jumping and cutting in a game. And that's going to be, because the reason is because that's the most stressful, and that is far and away the most damaging to the bone. Running and jogging up and down the court is not going to cause a lot of damage to a bone for the athlete. And then I'm gonna just kind of, beat up on wearables a little bit more, and that's that. Think about this: if your wearable device, a lot of times you're like, it's 90% accurate. So you think about it, you're like, oh yeah, that's cool. That device is 90% accurate, but know that it's 10% inaccurate, which means that if you're 10% inaccurate in measuring applied loads to someone, that means that you're going to be miscalculating or underestimating the micro damage by up to 60, 70%. That's why wearable devices are not often able to predict who's going to get an injury, because they're trying to look at load applied versus, reflecting it back to the amount of micro damage that this person is accumulating.
Hmm. Yeah, it makes me think. You talked about those high bone stress things, that the whole volume of the tendon question, and I feel like there's this safety mechanism built in where it's like once you reach a level of fatigue within a game or something, you don't even have the capacity to be explosive anymore. So I'm thinking that has to be protective of bone and tendon to where you're not even capable of doing those because you're fatigued. Unless you're like in a super conditioned state, then maybe you start those people tap into tendon bone damage more. So, that's just what a speculation. I would.
No, 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 there's a lot to that, and that's because, yeah, your muscle forces are the highest when you're the freshest, And so in NCAA basketball, we see that we'll just talk about ACL injuries. We see that ACL ruptures peak in the first half, typically in the first 10 minutes of an NCAA basketball game. And that's because that's going to be the most intense period of the game. Now, for NBA, and I love NBA. Right now, the playoffs are going on. I watch them every night. But anybody who watches the NBA knows that things don't really get real until the fourth quarter. And so when you look at ACL ruptures, then for NBA, that's when they tend to peak. They tend to peak later in the game. And it's not because of fatigue. It's just because those also correspond with the most intense periods of the game. And so I got to think the same is true with tendon. And again, we'll go back to like patellar, like our knee. Our knee is really responsible for braking forces. And so when you go in and you're doing like a dunk, or you're driving, or you're a soccer player, the faster you're running, it's not just the pushing off forces, but don't forget your foot's hitting the ground and you're braking as well. And so if you're coming in, you're cutting, and you're a very fast runner, those athletes that are springier and faster and better jumpers are going to get greater tendon loads, and they're going to be trying to control the braking forces on their knee even more. And so that's going to be the type of activity you should really be training for. And the same thing too when it comes to bone stress injuries. The athletes that tend to get greatest risk for bone stress injuries when it comes to basketball are going to be your most explosive athletes. The athletes who have the greatest muscle forces, the best jumpers. Also, there's a bone structure standpoint too. Those athletes also tend to have longer legs. They tend to have skinnier legs. Their metatarsals tend to be longer and skinnier. And I basically described everybody in the NBA now, but I mean, like those athletes, you got a very high muscle forces being transmitted through a very small cross-sectional area of a bone. And so that bone is going to start developing some micro damage earlier than if you have an athlete who is a plotter who has, I don't know, a larger tibia, for instance. They're not going to be at high risk for a bone stress injury.
Mhm. Um, this whole thing with tendons, I think it was Katja Hennemeyer with the C14, like saying how the tendon's built by the time you're 17. The same is existing with bone.
Well, yeah, so let's talk about that. So, yeah, so what you're asking is, do we just build all of our bone mass before we hit, like, say, age 20, and then it's kind of all downhill from there? And um, I mean, we used to think that. Well, first off, the number one predictor, and we often forget to mention this, the number one predictor of your bone health and bone strength and bone mass are your genetics. So, all you got to do is look at your fracture rate in your family. And if that's you, if you have some people in your family who've had particularly osteoporotic type fractures, or even fractures when they're younger, you should be thinking a lot about what you can do to maximize your bone health. So there's that a genetic component to it too. But yes, when we go through adolescence, particularly right around adolescence, that is the far and away the most important time to build bone mass and bone density. But most important, it's the most important time to build like bone diameter. And Stu Warden, a really amazing researcher when it comes to bone health and bone maturation. He's shown this really quite clearly, and he's looked at for instance, like baseball pitchers. And you can see this in baseball pitchers really, really quite well. And that's that when you look at not only like the amount of density that they have in their humerus, but also the diameter of it, and also the thickness of the cortical wall, the cortex of the bone, so the outside part, is so much higher because they've grown up throwing a baseball. And if you're in your 20s and you decide, and you'll say you can throw I don't know, 95-mile-per-hour fastball. Let's just say that you could throw it with your opposite arm. The humerus strength on the opposite side is about half that of your throwing arm, and you'll pretty much break your humerus right away. And not Brent, but Stu has done some really nice work in that area. Now, and that's a big reason why if you play soccer or you play basketball, what it does is and this is when between the ages of 9 and 12, so before you hit, full on puberty, when you're playing basketball or soccer, those are great activities. They're bending and twisting and, and doing all the different things to your bones that you want. Those individuals have a dramatically lower risk of bone stress injury when they get into their 20s, when they go and they're running collegiately or when they're in the military. It can have a very large protective effect. And not only that, but it also even goes into your 40s and 50s. So if you were a soccer player in adolescence, it really reduces your risk of fracture in your 40s and 50s. Now, with that said, we can still do a lot of stuff in our once we get out of our 20s to improve our bone health. And Belinda Beck, who is a researcher out of Australia, has done some really great work with people who have osteoporosis. And she's done some really nice randomized control trials that show that you can reverse osteoporosis and reverse osteopenia in older adults with a good and very well medically directed bone loading program. That typically also maybe have a nutritional component. But if you Google Belinda Beck and some of her Lift More study, I think was kind of a landmark study, and where she had them doing she has these people, they're a great video, kind of hilarious because they have these older individuals. I think about my mother who's 80, uh, doing that. I would love for her to get on one of these exercise programs. They're doing like heavy deadlifts and heavy squats, and they're because they can't necessarily jump as high. One of the things they're doing is she has them reach up and grab a hold of a pull-up bar off of a chair, and then they do drop landings up from high, and then they land soft and stuff like that, so they can get lots of loads. What she's showing is that you can reverse osteoporosis, and you can, if you're osteoporotic, you can become osteopenic. If you're osteopenic, there's a good chance that you can reverse that and become get back to normal levels when it comes to your bone density scores.
Um, this kind of between that whole thing of like you build it when you're young, and then um, this whole middle ground. You said the Sinding Larson Johansson, the Osgood Schlatter, Severs, Severs, is how you say that.
Hmm.
How are you looking at those type of issues? Is that a tendon issue, a bone issue? Is it neither?
It's a bone issue. It's a bone issue, and this is, I mean, it's a traction injury on the epiphyseal plate. You can really kind of think about them, all the same way. These are self-limit for the most part. These are self-limiting conditions. So, Sinding Larson Johansson syndrome, if you're not familiar with that, is apophysitis of your inferior pole of your patella. Osgood Schlatters is your tibial tuberosity, and Severs. I hate the term disease, but that's what it's called. We'll call it Severs heel. Is the epiphyseal plate of your calcaneus, and so we see that a lot. It tends to happen more in males. Obviously, it happens in females as well, but particularly when they're going through large growth spurts. And if you've ever had it, you know what I'm talking about. But it is what's considered to be a self-limiting condition, meaning that with appropriate load management, it will go away. Now, and it fluctuates from day to day, whichever one of those that you might be dealing with, or your athlete might be dealing with. But you can still do a lot for it. First off, if the athlete cannot run or jump without a limp, they should take the day off. That's that that's that area's way of saying, hey, you're just cooking it too much today. I need a chance to catch up with where we are. And it may fluctuate a lot from day to day, and it's kind of a little bit like the stock market. It'll kind of keep getting better, but you might have some ups and downs along the way. Now, I will caution people that they shouldn't just say like, "Oh, it's not a big deal, just train through it." Because unfortunately, in my career, I have seen two high school athletes that have avulsed their patellar tendons, who had Osgood Schlatters, who continued to be in. They were on doing AAU basketball and continued to play with it. Both of them ended up in a knee immobilizer. The one ended up having to get had to get surgery on it because the avulsion wasn't healing. So it does happen, and so you need to be a little bit mindful of it. My son, as actually, he's a big basketball player. And we got he's 10, and I just measured him this morning. He's almost 5'4", so he's pretty tall. And so you see us a lot when kids are growing. But we got him a basketball hoop in our yard, in our driveway. As soon as we got that, he developed Severs, and he would come in. He's like, oh, my heels are hurting, and so he actually calls it just a little bit too much basketball. And so that's kind of the rule we have, is like, look, you can keep playing as much as you want, as long as you can jump fine and all that stuff. But one of the big things that we found that makes a big difference there is I use heel lifts. I put heel lifts in his shoes. And so we do a 10 millimeter heel lift. And what that does is that reduces, that shifts his plantar flexors into more of an actively insufficient position. And so he can't generate as much force from his plantar flexors. And as a result of that, on days when he's really sore, he puts those heel lifts in, and he typically can do okay. And if he still doesn't get relief with the heel lifts, and I'm like, okay, you're going to need to sit today. But yeah, understanding biomechanics, particularly foot and ankle, can be really, really helpful when you're working, particularly with these adolescent injuries, whether it be this apophysitis or you're dealing with someone who's got like a true bone stress injury.
Mhm. I think I got a message a few weeks ago. A guy sent me a kid had at the tib of the tuberosity during basketball bilateral rupture.
Mm.
Was dealing with slaughter. I think it was at least. Now I lost the message and it's thousands of messages down, but it was fascinating. I didn't share it with the public because it's kind of gross. But yeah, with that group, that's kind of how you're looking at it. Because I get a lot of questions on the Osgood and the Cindy Lesson Johansson and those young kids. And I kind of I direct them to like Michael Rathleaf has some pretty good work on that
Yep.
of like keeping the kids active, but there's no like strict rehab these kids have to follow. You're just of that thing of like just kind of take it day by day.
Yeah, well, exactly, this is one of the things too that becomes a little bit tricky with like that sort of research. And Michael's amazing. His work he puts out is fantastic. And I think they're doing some really great work. Sinead Holden, who's with him, is also in that and his research group is part of that team, and she's doing some great work in this area. One of the things that's important is that the people who come to see like these big research centers who have Osgood slaughters, they're typically people that are pretty desperate. Their kids are pretty desperate. They've got pretty severe cases of it. And so I know one of the things that he says is that like, some of these people don't necessarily resolve over time. But I don't know. My experience is that yeah, there are some of those, but for most people, they will do just fine with some self limiting. As far as just reducing the amount of loads that they're doing. And the other thing too that really dramatically increases your risk of all these apophysitis is sports specialization. And we see a 400% increased risk in Osgood slaughters if you're on an AAU basketball team and you're playing a lot of basketball and you're outside. Like right now, my son, I mean, he's like I say, he's 10, he's 5'4". I'm sure you can imagine he's getting recruited to be on 3-and-3 teams this summer and his heels are really bothering him. Like, why don't you just do some mountain biking this summer for a while? It's not that he's in fourth grade. It's not that important. And so I think like those things like early intervention and particularly these pediatric injuries, I think is quite important. And I think education of parents, generally speaking, when I see someone who's got one of these like Osgood slaughters or Severs, and I see a good bit of it because people come in, they like, oh, my son's got Achilles tendinopathy, and as soon as I see a 12-year-old with Achilles tendinopathy, like that's being referred to me, I'm like, that's almost surely not Achilles. It might be, but the first thing you should always be thinking of like, what's the most obvious thing, and that's going to be probably a Severs heel. Generally speaking, the person you have to talk to the most in the room is the parent. You got to be like, hey, like I know your 10-year-old is NBA prospect or division one, but like I'm being a little bit facetious. The most important thing that is going to happen there is that we need to talk to the parents and say, look, the most important thing you can do for your athlete right now is not get them to specialize in sports and sample a lot of sports, and that's going to really help them not just from a skill development standpoint, but also from a musculoskeletal health standpoint as well.
Mm. Um, we went like an hour over what I planned, so thank you for not uh stopping me. But let's do this. I hate these type of questions, but I'm gonna throw it on you because the two things we talked was patellofemoral bone stress. Top three things you got for patellofemoral pain.
Oof, top three things. As far as treatment goes,
Yeah, because I think yeah, treatment for patellofemoral. Yeah.
yeah, I would say start proximal and then start going more and more focal loading on your patellofemoral joint. So I think that would probably be the like number one thing I would say. Number two would be use your adjuncts wisely. So choose the ones that work well. We know that an off-the-shelf foot orthosis is no different than a custom orthosis. Go choose a foot orthosis that works really well for you. If it does seem to reduce your pain, then use it in your rehab. If it doesn't, there's no sense in sticking something extra in your shoe. Same thing with patellar taping. We know that there's good evidence there supporting the use of patellar taping for rehab. And the whole point of those adjuncts is not that they're magical or anything like that. It's because when you're on the knee extension machine or on the leg press, you can go one plate heavier. And so you're able to get more stimulus on this person. And so that's what adjuncts are supposed to be used for. How can I get more load on this person is typically the question I'm asking myself with almost all patients. And if an adjunct is involved, then we're going to go for it and do that. The third thing, I guess, would be keep the activity levels as just as high as possible. And whatever you need to do to be creative, cycling is one of the best things you can be doing. As long as the bike is fit appropriately. For the runner, I would say uphill treadmill running. If they can't do uphill treadmill running, do uphill treadmill walking. If you're going to do walking, increase the incline. So rather than running at 3 to 5% for uphill treadmill walking, you want to maybe increase it to 8 to 10%, which is pretty steep. And if you're doing that, you're going to be getting a pretty good workout. So, I do that a lot with patients that have iliotibial band pain as well, and it seems to work really quite well. And of course, obviously, you need to start lowering the treadmill down after a period of time. But
That was another thing I wanted to talk to about IT band, but we're not going to get into that. But one of my college basketball friends, he is going to run a marathon this summer, and he messaged me a month ago that he has pretty bad. He said runner's knee. It's like patellofemoral pain, but those are some pretty practical things I think he can use because I didn't really have a good answer for him. But it seemed like he just did too acute overload, and then just infrequent loading for like many days where it was not a good buildup, and that's a case of someone doing their own program. They're never going to be that smart about it.
yeah.
You got to get that video up of the taping, and then I can put that in the notes.
Yeah, I'd be happy to do
Yeah,
that.
yeah. For the bone stress, top three treatment
For, treat-
treatment issues. Yeah.
for treatment, hmm. Okay, number one, no pain is allowed. And so, unlike patellofemoral pain or Achilles tendinopathy, where some pain is maybe not only just okay, but and for the case of tendinopathy, usually if you're not experiencing some discomfort during at least some of your exercises, you're probably underloading that patient. That's not the case with bone. If you experience someone who's recovering from a bone stress injury, if they're experiencing pain during the loading bout, that is too much mechanical load. The bone is not strong enough to tolerate it, and you're irritating the site of the bone stress injury. Secondly, on that is if they get pain upon or later in the day or that night or upon waking the next day, you've really overcooked it. And what's happened there is that bone marrow edema has increased. You've really overstimulated the bone so much that there's increase in bone marrow edema, and it's going to take a couple days for that to cool off. Like most athletes, when they have pain, not during the session, but later, they're like, oh, I could do it. And it was fine, but I did get a little bit sore later on. It's actually that pain that you get after the session that you want to care the most about. I mean, both of them are really important. But if a patient gets pain after that loading session, you need to take 3 days off and just do some non-osteogenic cross training. So stationary cycling would be a great thing to do. Ease up on the strength training, and then a good rule of thumb is to go back one step in your progression and just pick up the basically where you left off. And the way I explain this to athletes is like, hey, look, you didn't refracture. All right, we're just progressing too quickly for your body's physiology to adapt to these loads, and we just need to ease up the gas a little bit and let your body catch up with it, and then we'll just pick right back up, and it's no big deal. So that would be number one. Number two, I would say don't think about impacts anymore when it comes to lower limb bone stress injuries. Always think muscle. And so if you're trying to get more load on the bone to get the bone stronger, you want to be thinking about how can I load this muscle more? And a lot of times it's going to be plyometrics because plyometrics, no matter where it is, you're going to get the greatest muscle forces out of something. That doesn't necessarily mean it's going to drive her, from a muscle hypertrophy standpoint, because that's different. But from a bone standpoint, muscle forces are king. And I would say too, the same thing too, when they go back to sport, is that you need to really be thinking a lot about muscle forces. So luckily, you don't need any sort of sensors to be thinking about plantar flexor forces, right? I mean, I think we've already talked about like different types of activities that I think we all intuitively know what's going to really work your plantar flexors a lot. So if you've got someone who has a tibial bone stress injury, you really want to be careful about not putting them in like racing flats or like track spikes right away, because it's going to really increase your plantar flexor forces, which means it's going to really increase your tibial bone forces. We didn't really talk about this injury at all, but navicular bone loads as well as metatarsal bone stresses, those are almost perfectly correlated with your plantar flexor forces. And that's because your foot is transmitting the forces of your plantar flexors so we can have a propulsive force. And so if you want to control loads on your metatarsals, you should be thinking a lot about controlling your plantar flexor forces. So I think those would be the three. So no pain, If you want to get bone stronger, think about how you can maximize muscle forces. And the third thing is if you want to control bone forces so you can ease this person's transition back to sport, think about controlling those muscle forces on that end of the spectrum as well.
Perfect. Um, Tell everyone where they can find you. I saw you have you have some courses online. If you want to talk about that,
Yeah,
go ahead.
yeah, I
Yeah.
do. Yeah. So you can find me at montanarunninglab.com. That is our webpage. I'm also that's our Instagram handle. So Montana Running Lab. I have an online course that we're offering. We actually just released it about a month ago. So that focuses on the running athlete. However, there's a lot in there about strength and conditioning for endurance athletes. There's also a lot on tendon health, how we can target different tissues differently. So how you would prescribe loads for muscle versus tendon versus bone, and return to run process. But also, I would say probably more than a third of that course is on bone stress injuries and maximizing bone health in the running athlete.
Mhm. Perfect. All right, Rich. Thanks for coming on.
Yeah, thanks, Jake. It's been a lot of fun. I enjoyed it.
Yeah.